Good morning and welcome to 2022 Johns Hopkins Alumni Weekend. I am Betsy Rutherford. I am a gift officer in the Department of Psychiatry and Behavioral Sciences, and I have the great fortune to work with today's speaker. So today's speaker is Constantine Lyketsos. He's a native of Athens, Greece. I'm going to stop there and mention that today is actually Greek Independence Day. So I did, in fact, wear my Greek colors, and although they conveniently are Hopkins colors too, so that works very well for me. But it is the 201st anniversary of Greek independence. So that it was very nice of Dr. Lyketsos. He's essentially here on our 4th of July. So thank you very much for being here. He is the Elizabeth Plank Althouse Professor at Johns Hopkins, and he also chairs the Bayview Department of Psychiatry and Behavioral Sciences. He is an alum of Athens College, Northwestern University, and received his MD from Washington University in St. Louis. Following that, he came to Johns Hopkins, where he completed his residency and served as chief resident in the Department of Psychiatry. He also completed a fellowship in clinical epidemiology. He is a world-renowned expert for the treatment of Alzheimer's disease and Alzheimer's and related disorders, and he's an active clinician, teacher, and researcher. He founded the Johns Hopkins Memory and Alzheimer's Treatment Center, which he directs. He also founded and created the Richmond Family Precision Medicine Center of Excellence in Alzheimer's disease, and that was created 3 years ago. So that's the direction. You'll hear much more about that this morning. He is also the associate director of the NIH-funded Johns Hopkins Alzheimer's Disease Research Center. So you can tell where he has spent his time. Dr. Lyketsos has received multiple awards. He's authored over 500 articles as well as 5 books, and his work has been cited more than 62,000 times. But I think, knowing him, one of the things probably he's most proud of is that since 2001, he has been named one of America's top doctors by Castle and Connolly. So this morning, I am very pleased and honored to welcome Dr. Lyketsos.
Kind of embarrassing after an introduction like that to not know how to handle a microphone, but good morning to you all. Thank you, Betsy, for that wonderful introduction. I shall demonstrate the Greek flag socks. Last year was the 200th anniversary, and when I was growing up, that's one of the days that I was always looking forward to. The 200 years of independence, and unfortunately it's something that COVID robbed us of. So you can imagine what's going on in Athens today, which is the opportunity to celebrate. I'll take a quick historical note aside, especially given the times that we are living in with the war around what's a nation, what's an empire. Greece was the first independent state in Europe that started this concept of nationhood that I think as a humanity we're still struggling with. So 200 years worth of a debate about independence of a nation from an empire. Welcome here today. My job is to mostly stimulate questions. So Betsy and I did this last year by Zoom. The format, it'll be a brief talk from me. I think I only have about 10 slides trying to stimulate questions. And then we will pull those chairs over, each have our microphone, and get a conversation going with you, because I find the most interesting and helpful way to do this is to engage you all. After all, you're the ones who have questions, and hopefully we can give you some of the answers. So there you have it, a few pictures of Independence Day. So I'm going to talk about these topics. I won't enumerate them. I believe we can make my slides available down the line if anybody wants to have a look at them. Let's start with public health impact. Before COVID hit, we were thinking that dementia was the next pandemic. And in fact, definition of a pandemic is the increase in frequency of a condition everywhere as opposed to in a particular locale, which is the definition of an epidemic. So based on what you see here, you can appreciate the counts of people alive with dementia across the world at different time points. Oops, I did something bad here because I was trying to, all right, I was trying to get a pointer, which I don't have. But anyway, what you see is counts by continents at 2015, 2030, and 2050. And this gives you a feel as to how we anticipate this pandemic will unfold worldwide. These are not percentages. These are numbers of people alive with dementia at any point in time, unless we have what you might call a cure. It also, at the bottom, I'm giving you the reminder that when you're estimating how many people are affected by dementia, you've got to count in the people taking care of the people with dementia over this 3 to 10 year process, which is the 95% confidence interval for how long someone with dementia lives. So we're talking potentially close to 750 million people affected on a daily basis, living with dementia in some way. Very substantial. And in the US, by the time we hit 2040-ish, this will be the single most expensive healthcare condition. So very significant public health impact. So this is probably the most important slide. And if you know the answer to all these questions after I tell you what I'm going to tell you, on this slide, you can tune out and then see if you can remember them later on at the end. I always get asked, what's the difference between dementia and Alzheimer's disease? I'm going to make a small attempt here to help you think it through. So at the top, we have usual cognitive aging. People always ask me, am I aging normally? And my answer is, I don't know what normal is, but I know what usual is. So there is a trajectory of memory and thinking and other aspects of cognition that people usually follow as they get older. And we really quantify that in terms of where you stand within your cohort. Are you on the cognitive testing that we do? Are you in the 10th percentile, the 50th percentile, 90th percentile? And those cohort aging effects are pretty well known now into the mid to late 90s. So if you were 60th percentile at age 40 and you're still 60th percentile at age 90, you have usual cognitive aging. At age 90, you won't be testing as well as you were at age 40, but you're on your curve. You're on the usual trajectory. So that's usual cognitive aging. Mild cognitive impairment is where you're falling off your trajectory. So now you're at the 30th percentile or lower, whence for a lifetime you were on the 60th percentile. So you've fallen off the curve, but you're really still pretty well functioning. You're able to, my test is usually, can you live independently? Can you do the kinds of things that you deal with day to day? So that's mild cognitive impairment. Mild cognitive impairment is important because over time, most people with MCI go on to the next stage, which is dementia. Dementia is you've fallen off your curve and you are no longer functioning the way you were. So you're getting lost a lot when you're driving. You can no longer handle money. You can't shop. Or worse, you're having trouble attending to how you organize your clothing or your more basic activities, bathing, dressing, and that sort of thing. So that's what dementia is. Dementia is a clinical state. It's the condition of a patient or a person. They've fallen off their cognitive curve and they are no longer able to function independently. That's it. Now, what causes dementia is where we start going into the brain and we start asking the question, why is this person falling off the curve? And we have discovered with many years of research that there is some process in the brain that is damaging the brain and is therefore damaging memory, language use, orientation, all those other things that we put together to call cognition. So there are a number of brain diseases that do this, and you see at the bottom, the most common four. These are reasonably well characterized pathologic processes. We know what they look like under the microscope. Most people have more than one of these, but Alzheimer's fits here. So the difference between dementia and Alzheimer's. Dementia is a clinical state. Alzheimer's disease is a disease in the brain, which causes dementia frequently. Alzheimer's disease can be in the brain with no symptoms. So there is not a tautology. You can have dementia that's not Alzheimer's. you can have Alzheimer's with or without dementia. So maybe if that's not clear enough, we can get into that a bit more in the Q&A. But the important point is, how do we know in a clinical environment? So in a clinical environment, to know if you have dementia, we just need basic clinical testing like the Montreal Cognitive Assessment, which you see here. It's a 30-point assessment. It's actually a pretty good discriminating tool to decide whether someone has dementia or not. MoCA got popularized many years back when President Trump, well, we don't know exactly how he scored, but he took it and he talked about it a lot. If you want to know whether you have Alzheimer's disease, you can only know by studying the brain. This is a picture of a PET scan that measures the amount of amyloid that is in someone's brain. Amyloid is a protein that's linked to dementia. And that's the only way you know whether you have Alzheimer's. In the past, we could only know whether there's Alzheimer's in your brain by taking a piece of it and studying under a microscope. Sign up for a brain biopsy, anyone? So now, though, we have tools, diagnostic tests that can quantify the parameters that we see in the brain of people. So we can know pretty confidently right now if someone has Alzheimer's in their brain or not with these tools, some of which are PET scans. There are a number of other tests as well. That's the difference. So if someone tells you, I went to the doctor, they took an MRI, and they told me I don't have dementia, the MRI doesn't show any, you know you go for a new doctor, right? Because they don't know what they're talking about. You cannot see dementia in an MRI. All right, biomarkers, just to mention that these tools that we have now, this is the MRI. I don't have a pointer. Maybe I do, and I don't know it. Okay, well, I wish I could, because there are some parts of the brain called the hippocampi, which are shrunken here. And so you can see the hippocampus affected by Alzheimer's on an MRI. We have various ways of quantifying the MRIs digitally. So before I showed you just a visual look of an MRI. Now I'm showing you a visual read that shows you functioning in different parts of the brain using a methodology called DTI. Oh, the middle button is, see, I don't see the middle ever. Thank you. How do I go back? There we go. Okay, so the middle button, thank you. These are the hippocampi. And this black area is fluid. So what has happened is the hippocampi have shrunken. They usually fill this area. And so this is what's happening to this person. Their hippocampus is getting smaller, and the area around it is backfilled by fluid. So this is just a more digital analysis. The point I'm making here is we're less and less relying on the eyes of a doctor to read findings on an MRI, and we're going more to these digitally automated ways. So we acquire the MRI, we send it to a sophisticated computer, it runs it through a program, and it pops out some value, which might be, this is the size of your hippocampus, or this is your functionality in this part of the brain, et cetera. So we're transitioning to a digital capacity. Here's a different kind of test. These are PET scans. You all know what CAT scans are. So in a CAT scan, you're sending x-rays through the body. You have a reader at the other side of the body, and that tells you something about what's inside the body. In a PET scan, instead of sending x-rays through the body, we're injecting into your bloodstream a molecule which has a teeny bit of radioactivity, and it is emitting positrons. PET scan, positron emission technology. That molecule has a property, let's say in our case, it will stick on amyloid in the brain. So in an amyloid PET scan, you're getting an amyloid injection, goes into your brain, and for a brief moment, which may be a few hours, it sticks there emitting radioactivity, and that allows us to quantify how much amyloid is in your brain. That's what a PET scan does. So you can substitute the amyloid with a different positron emitting molecule, and you can image a variety of other things in the brain. And so here, we're imaging glucose. Here, we're imaging tau. You can see how much more sophisticated this is. This is another protein we see in the brain in relationship to Alzheimer's. And with this different molecule, we can image tau throughout the brain. Eventually, where we want to go is more easily accessible and less expensive tests. They don't have PET scanners in India and Africa as frequently available as we have them here. So this is called CSF sampling. Women who have had epidurals, they know about this process. There's a small needle with some anesthetic, goes into your back. And in the case of an epidural, it introduces an anesthetic. But in the case of CSF sampling, we push it in just a little bit more, and we take out fluid. This is the cerebrospinal fluid that circles around the brain, and we measure amyloid and tau in that fluid. And we can measure other things as well, right? So this is the other tool that we have, but that involves a somewhat invasive process. Our colleagues in Europe, maybe it's a different form of medicine, maybe a little bit more paternalistic. Patients are more than happy to have CSF sampling. We find it a little harder. People would rather have a PET scan than CSF, but it's a very routine process. The future does not want to come up. The future is a blood tube. So we at Hopkins, many others, are developing blood tests. So if we want to know how much tau and amyloid in your brain, maybe we want to find a way to measure how much tau and amyloid is in your blood under certain circumstances. So in the future, maybe in the next 2 or 3 years, we'll be seeing diagnostic tests using bloods. So that's what biomarkers are. Let me introduce another concept. I hinted at it. Right now, we're operating under the idea of the amyloid hypothesis. That basically says that throughout your life, there is misprocessing of a protein that we all have called A-beta 1 to 42, amyloid protein A-beta 1 to 42, roughly the same for our purposes. That accumulates over a lifetime and initiates a complex cascade which leads to the tau tangles, the loss of neurons in the brain, and eventually symptoms. That's the amyloid hypothesis. What this means is that you don't know it until this. And we're realizing that the stuff before symptoms is probably ongoing a decade or two. So that's why we talk about a pre-symptomatic phase. It's this period of time where the disease is unfolding in the brain, but the person doesn't know it because they don't have symptoms. This is important because this is where ultimately prevention comes into play. This is where we think we will be able to introduce therapies so that you don't get the symptoms. And many efforts have been initiated with amyloid-oriented treatment. So far, no successes to develop a drug that's really going to change this cascade. But if you believe the amyloid hypothesis, this is going to eventually find a cure. The other point I want to make is, let me start it with a quick question. Raise your hand if you think Alzheimer's is a memory disorder. That's it? Just one person? Okay. Raise your hand if you think Alzheimer's disease is a disorder that causes anxiety. Good. Okay. We're ahead of the curve. The point I'm trying to make here is that memory is just one part of the brain that's affected with a disease that's spreading throughout the brain. It therefore stands to reason that parts of the brain that regulate behavior can, and in fact are almost universally affected. And so people get a range of neuropsychiatric symptoms, depression, anxiety, delusions, hallucinations, and so on. These are important in two ways. They are so frequent that they are often problematic. And as doctors, when we're treating people with dementia or even people with MCI, these are the most troubling symptoms. So in someone with Alzheimer's, I'm managing anxiety or depression or problem sleeping much more often than I'm managing other symptoms. The other reason this is important is this picture to the right. This is a survival analysis. If you get these symptoms early on, you move to the severe dementia faster. That's the survival of the red line versus the blue line, which is you don't have these symptoms early on. Again, an opportunity for prevention. If we introduce management of these symptoms early, do we change the parameters? You don't progress as fast. That's one of the targets of effort. Home-based care. Raise someone if you would like to move out your home into a nursing home at around age 75. Raise your hand if you would rather stay at home for the rest of your life. All right, we're all on the same wavelength. And yet, our healthcare system right now is really not set up properly to take care of people with dementia at home. We can get into the details, but take it as a fair statement. It has to do with how doctors are paid. It has to do with what Medicare will pay for, et cetera, et cetera. So what we're trying to do is develop a really innovative approach of delivering care at home with minimal contact of bringing people into clinics, which means the ability to diagnose, intervene, treat, evaluate needs in the home of someone with dementia using modern technology. We call that Mind at Home. We've already shown that by introducing this early on, we delay exit from home to the nursing home by about 9 months. How much does 9 months of a nursing home cost? A whole lot of money. So if we can delay that, it means we can pay for Mind at Home, which is one of the approaches that we have. So delaying exit is showing improved quality of life. One of the few randomized studies that shows that an intervention can make quality of life better for someone with Alzheimer's dementia. And also a reduction of the hours per week for the caregiver. So with Mind at Home, our caregivers spend about 16 hours per week, 16 hours per week less in caring for someone with dementia, because the system either introduces other caregivers or makes changes that makes it possible. And overall, it saves money. So home-based care, whether it be the Hopkins Mind at Home or some other approach, this is the future. And I look for it because we believe that the payers eventually will realize not just that the costs are lower, but also that this makes a big difference to patient care and caregiver care. So where are we in 2022? We're actually in trouble from the point of view of finding a cure. After 40 years, we only have 4 drugs, and none of these is really tackling the disease. There was a little controversy last year with a drug called, what is it, Betsy? Abracadabramab? Or no, it's aducanumab. This drug that the company was actually going to shut down because of a futility analysis that says, oh, it's never going to work, so we're stopping the research, to a few months later, the company coming back and saying, oh, wait, this works, we should get it FDA approved. It was FDA approved last year in an accelerated pathway. The problem is that whereas it's very, very good at clearing amyloid from the brain, it really doesn't shown to help people. And it's extraordinarily expensive, not just for the drug, but the whole process of delivering it. It's an IV drug. You have to go into an infusion center once a month and be monitored for a few hours, et cetera. So that's why I say we don't have clear disease-modifying therapies. Aducanumab might prove to be itself. And we think it's because we're too simplistic in this amyloid hypothesis, but that rather we think it's going to turn out being something more like this, where everybody's got their own pathway to dementia. And it's not just about A-beta oligomers, but it's about things happening before these oligomers and in between those and the tau, ultimately suggesting that we're going to need a different therapy at a different stage for a different patient. We might need an anti-inflammatory therapy if we're upstream from amyloid. We might need a different anti-tau therapy if we've got robust tau development, et cetera. Not one disease, many pathways. The field is understanding this process. And the term we use for this, which is big at Hopkins nowadays, is precision medicine. The right treatment for the right patient at the right time. And we have started a precision medicine center at Hopkins for this purpose. So what our Precision Medicine Center is doing, this is more of a slide I give at scientific meetings, but the point is to end up in defining down here, bottom right, the 4, if you will, hypothetical distinct forms of Alzheimer's disease using a combination of medical record data, brain MRIs, and other imaging studies, and a variety of blood tests with some fancy new biomarkers that we are developing. Well, you might say, what should I be doing now? And we can make available to you a simple one-page flyer that I'm reducing to here. So these are the kinds of things that you can do now, not necessarily easily, but I believe make a big difference. Staying healthy is probably the most important thing. About 30 or 40% of people who first develop symptoms develop it later in life, develop it after some sort of acute illness or surgery. So the sense is there that someone may have a percolating process in the brain. Remember the pre-symptomatic phase I was talking about? But here comes a pneumonia or a bad cold or an exacerbation of diabetes or a colonoscopy with deeper anesthesia than's necessary. 6 months, 8 months later, you start having the development of memory symptoms and dementia. So staying healthy would at least manage some of the triggers and drivers of developing dementia. Who here sleeps at least 7 hours every night? Good for you. Very important, we're realizing. Many reasons that relate to the biology. It does seem that one of the things that happens in certain phases of sleep is clearance of amyloid and other toxic proteins from the brain. So if you're not getting enough, what's called slow wave sleep, over a decade or two, you might have a problem with accrual of amyloid. Limit the effects of stress. Anyone here very stressed? Anyone here medium stressed? Not stressed at all. Oh, we got some of those. All right. So this is one of the hardest things to manage, is the reduction of stress. I think that meditation, mindfulness, approaches such as that, taking time to yourself, good self-care, end up being very important. One of the good news is I'm seeing my children's generation actually being very concerned about this and introducing practices at an earlier age than we certainly did. I'm not telling you how old I am, but I'm old enough. So I think that's an important thing to start appreciating, is how critical it is to do these year in, year out. It's not just about doing it once or twice, but it's the practices and habits of a lifetime around sleep, around stress reduction methodologies, about personal self-care that is very important in preventing dementia. And there's the triumvirate of keeping physically active, keeping mentally active, keeping socially engaged, many different ways to do that. You know, I realized, Betsy, I used to have that basket that I would give out that would walk you through all of this. We could have gotten one. And of course, Mediterranean diet is the only diet that has some hint of being important in preventing the development of dementia. And I will give 10 points to whoever tells us the most important component of a Mediterranean diet. You're close. It is a Greek product, but it's a different Greek product. It's red wine from Santorini. So we'll move into questions. Oh, go ahead, sir. The grapes. It's the grapes. It's those lava-infused grapes. Am I kidding? Only partly. There's evidence that red wine actually does prevent dementia because of antioxidant properties. So let me wind it down, and maybe I could invite Betsy up and we take questions. And I see you, sir, here in the first row as having a question. Let me see if I'm capable of moving the microphone.
All right. Thank you, Dr. Lyketsos. We're going to go ahead and move. Yes, go ahead. I appreciate it.
We'll just sit here and talk.
We're gonna go ahead and do some Q&A, and I'm gonna moderate from here. For COVID protocols, there are microphones at the front here, and we're just not passing out microphones, just so we're gonna go ahead and do that. But while we get ready and while you think of your questions, I'm gonna start with a question for Dr. Lyketsos. Kostas, because he really does prefer to go by Kostas. Kostas, talk about what the pandemic did to both your patient base and what did you learn during this time?
Yeah, I think the pandemic and really more the shutdown than actual infection has been very devastating for patients. Clearly, folks with Alzheimer's are vulnerable. Keeping them away from COVID if they're living at home has not been too hard. All of my patients have pursued immunization and social distancing and using masks and all that. So we've not had that many folks who actually got COVID, but the social isolation has been devastating. And so we've had a lot of people developing symptoms unexpectedly. Remember the biologic stress point I was making? Folks who were doing fine, spent 6-12 months in pretty much COVID isolation, now start developing symptoms for the first time. We're seeing a lot of folks like that. But we're also seeing people who were on a pretty even keel, perhaps with slow functional trajectories, getting worse a little bit, who had really steep dives because they were not engaged mentally, physically, and socially. To me, it reinforced the importance of that. Even if you have mild dementia, the more you do to keep active and engaged, the better you're going to do in the long term. So COVID has been quite the hit. So should we open it up? Yeah, if you could come up, maybe if you're comfortable lining up at the microphones.
Kostas, you want to just talk about the research implications? You had someone on your staff who did a little bit of research.
Yes.
And then we'll go to questions.
So one of my colleagues in our Precision Medicine Center, Dr. Tracy Van Oorsel, who's a neuropsychologist, has by now followed up about 500 people who had acute COVID illness and who were treated at Hopkins. And has documented that about at 6-ish months after leaving the hospital, after their acute illness, they continue to have chronic psychiatric symptoms, primarily depression and anxiety. But about a third have still got significant, testably measured cognitive change, particularly decision-making, executive control, as well as memory. So this idea that some people will continue to have symptoms and that there could be evidence of brain damage is substantial around COVID. And I should mention very quickly, her paper that was published is now one of the most popular papers in the journal that it was published. There's a lot of interest out there. So we'll alternate. I think, sir,
I was going to say, we'll start over here on my right.
Hi, good morning. I'm Nick Pratt, class of 72. And I just have a question about your general approach toward the treatment of sundowning in Alzheimer's patients.
Right, so the treatment of sundowning, typically to me, sundowning means that later in the day, someone gets more confused, perhaps irritable, agitated. And in my experience, it has little to do with when the sun goes down. It tends to happen when people are tired. So the first consideration is this a new thing and could it be attributed to something like a bladder infection? You'd be surprised. So the first step is a workup, an evaluation of why is the sundowning happening. If the conclusion is we don't have an acute medical disturbance, then we start asking the question, because it has to do with fatigue, how well is the person sleeping? And oftentimes if we fix nighttime sleep, maybe introduce a nap in the afternoon, we can solve the problem. But there are yet other patients who have difficulty with sundowning that involves a lot of moodiness and anxiety and worry and irritability. In a situation like that, we might introduce certain medications very cautiously. So that's generally what could be the cause, how well managed is the circadian cycle, what can we do with activities to manage it, and if we're not succeeding, we have reasonably effective medicines, but we try to avoid them.
Hi, my name is John Marin. I was president of the class in 1970. And I'm going to start with a piece of Greek trivia. I had $10,000 to spend as the prez, and so I paid a Greek gentleman, Ted Kuriatsos, to create an aluminum sculpture that's right over on the other side of Shriver Hall. The plaque's been taken away, but I wanted to give him a shout out as a Greek sculptor from the Maryland Institute of Art. Okay, that's...
On behalf of all Greeks, thank you.
So if you go out and check it out, it's over here. It's the silver sculpture.
Well, I'll make sure that the president of the Hellenic Student Association, right, Ariadne, at Hopkins, make sure that the plaque gets restored. Sorry, that was an aside.
Yeah, I'm meeting with my class this afternoon. That's a topic of discussion. Replace the plaque. Give Greeks their due.
Thank you.
Okay, so I have like maybe two questions. My father passed away of brain cancer. He originally had prostate and went to his brain. But then he really got serious disorientation, memory loss, probably Alzheimer's, and died. But what is the percentage of sort of the biomarkers before Alzheimer's? You mentioned colonoscopy, which I've had 3 of, but also physical injury, diabetes. What are the percentages of these things that might lead up or exacerbate Alzheimer's? You know, what's that range? And I personally have, using a sleep apnea machine, you know, CPAP for about 4 or 5 years. How much does that help or prevent, you know, the brain, you know, going sideways?
Well, terrific questions. I'd like to hire you as a co-investigator because a lot of the questions I don't have clear answers for.
Yeah.
Let me take up the sleep apnea piece. The best evidence I have is a dozen or so patients of mine with mild memory symptoms whose symptoms went away with proper correction and maintenance of sleep apnea
No, it
management.
might have gone away in the last 4 years.
So clearly now, whether managing sleep apnea at 55 makes a difference, whether you'll get dementia at 70, I don't know. It's a tough question to answer. We do know that the major predictor of whether you have these biomarker positivities is how old you are. So if you take 90-year-olds, 40 to 50% have positive amyloid biomarkers, whether it be in a PET scan or in a CSF.
What age is that again?
90.
At 90, 40%.
Yeah. But you know, at 90, 100% of men have prostate cancer. So
right. Oh yeah.
Yeah. So the clinical significance of these biomarkers is somewhat unknown. How often does having surgery, for example, make you get abnormal biomarkers? Dr. O, one of the colleagues in Precision Medicine Center, showed that about 90% of people who have hip surgery after a fall have Alzheimer biomarkers before the surgery.
So what's the drug you use with a colonoscopy? Propofol? What is it called?
It's propofol is one that's commonly used.
Would that damage the brain, twilight sleep?
It's so unclear. And there is a very active effort to sort out the effects of the drugs, the anesthesia, the condition for which you need the anesthesia. It's a very complicated, thorny issue.
Thank you much, Lynn.
You're welcome. Thanks for the question.
I'm Bill Henderson, class of 72. First of all, did I understand you say afternoon naps are good things?
I said afternoon naps can be a good thing.
Okay.
I'm Greek, remember? Siesta?
Okay. My wife's mother and aunt both have dementia, and my father passed away from Alzheimer's. I know genetics is one of the things that you mentioned. How likely is it that each of us is going to become affected by Alzheimer's?
Yeah, that's a common question. So let me just quickly go over the genetics. So out of 100 people who have Alzheimer's dementia, about 5 of them are getting it because of a bad gene, a single bad gene. Those conditions tend to happen earlier, and those genes are knowable, at least many of them are knowable. The rest is what we call polygenic or sporadic, where there are maybe 30, 40, or 50 genes involved. So we're not quite where we can do a genetic test and predict a risk. We do know, and to answer, if someone is the child or also niece of someone with Alzheimer's, at a younger age, like 60 or 70, they have an elevated risk. Maybe it's double or triple the population. So instead of 1 or 2%, it's 3 or 5 or 10%. At an older age, the background frequency is so high, it's about 35, 40% at age 90. If you make it to that age, having a parent with Alzheimer's doesn't really change your risk very much. So it's a dynamic issue. Unless you've got one of the bad genes, then the sporadic thing is less clearly understood.
Good morning, thank you. Jerry Brecker, class of 67. So in the 55 years since we graduated from here, there are at least 3 conditions that were more or less unknown and that have become rampant: obesity, autism, and Alzheimer's. And since then, and I'm wondering whether you think there's some environmental or other broad spectrum that's responsible for these things that we didn't know about, didn't pay any attention to, and now are rampant in society.
Yeah, that's a very interesting question. I don't know about autism. I mean, I don't know it well enough. The only thing that my eye seems to remind me of is the increased age of parenting has to do with some of the developmental challenges that children may have. But truly, I don't want to pretend that I'm an expert on that for autism and environmental effects. Obesity, yes. I mean, we're in an environment where we have food ads, large portions at restaurants, lots of sugary drinks, et cetera. We're in this country and increasingly around the world, we're in an environment where consumption of food is rewarded as central to a lot of activities. And so I think that has a lot to to do with it. Of course, obesity is linked with a diabetes epidemic, which is a driver of Alzheimer's. So I can see a link there between obesity, Alzheimer's, and diabetes, but I don't know that there are other variables that I'm not thinking of.
Yes, my name is Yvonne Rosanelli, and I'm the primary caregiver of my father. He's 93, a retired physician, and he has full-blown dementia. He's never been diagnosed with Alzheimer's, so I don't really know if he has it. But my question is about the Sundowners. I try to keep him busy throughout the day with physical activity so he doesn't get that in the evenings, and that's been working pretty well. But sometimes he'll get into a loop of thinking that he lost something, and he knows he lost it, he doesn't know what it is, and I don't know how to break him from that loop. What would be suggestions to get him out of that? I lost something, but I don't know what it is.
So I'm going to be careful and not advise you specifically about your dad because he's not my patient. So I'll give you a general response around that kind of symptomatology. We know that the Alzheimer's brain disease is associated with damage to a part of the brain that produces a chemical called serotonin that's important to the regulation of mood and behavior. And many times these behaviors that you're talking about are because of a serotonin deficiency. So we will not infrequently have success in treating this with SSRI medications. So things like Prozac or Zoloft, or more likely what we use is something called Lexapro or citalopram. There are other medicines as well. So if you can't have a behavioral solution to these problems, which sounds like you're pretty good at that, perhaps talk to the doctor about those kinds of medication options.
Okay, thank you.
Kostas, you want to just mention the concept of joining their journey? Because this question's reminding me of that your nurse, Andrea, will talk about a lot in terms of not fighting them.
Oh, yeah. Well, you say it.
Well, just the idea, and I just actually had my mother go through delirium in the hospital, and so I called Kostas's nurse and I said, what do I do? And she said, you join her journey. And so instead of fighting her and saying, no, you're not being held hostage in the hospital, you want to get out, so here's our plan to get you out. So you lost something, what is it? What's so important about that? And instead of fighting them on the actual, what is going on and just proving them because they're scared, is to actually just join them where they are. And I thought that was one of the best.
Yeah, I'll give you another example. My former father-in-law, this is 20, 30 years ago, his mother had dementia. She would call every day distressed that the children were lost. And he would always try and reassure her, that they're not lost, don't worry, everything's fine. Eventually I said to him, change your tact. And so he thought something up the next time she called, Mom, they found the kids. And it was done.
Hello, thank you. My father passed away from Parkinson's. He suffered from that. And we had periods where he would alternate very calmly between hallucinations and lucidity. And is that just, how would you describe that in terms of the common use of the term dementia?
Yeah, so there is a condition that's related to Parkinson's that we refer to as Lewy body dementia. Lewy body dementia, and we believe some forms of Parkinson's, affect a part of the brain called the reticular activating system. That's the job of the RAS, is to keep you awake and alert. So when the RAS is affected and not functioning as well, these alterations of alertness and non-alertness can occur. People can go in and out of dreamlike states. They can have what are called hypnagogic hallucinations. Sometimes I think we all might have had the experience as you're falling asleep, you have some kind of quasi-hallucinatory experience. So I would explain this that way, that there was potentially some disruption in the arousal system and there was this shifting back and forth between awake and sleep. There's a more fancy term, REM sleep behavior disorder. But yeah, that I think is my best explanation.
Hi, I'm George Rosanelli, class of 71. My question relates to the diagnosis of Alzheimer's disease, and in particular amyloid. The eye is an extension of the brain, and amyloid collects in the retina, and it correlates with the amyloid collecting in the brain. There's a very, very common instrument that retina specialists use called Ocular Coherence Tomography. And there are papers that that say that they can identify this amyloid with that very, very common machine. In my neck of the woods, which is Florida, it doesn't seem to be clinically available. Can you update it? Is it too far outside your field to be talking ophthalmology, or can you update us on that?
I can give you a brief update. I think this has been less active as a field in a number of years, but I think what you say is fundamentally correct. And the added piece is that if you eat large quantities of curcumin, actually, these amyloid plaques in the retina are more visible. And so there's a theoretical basis for why you might use OCT, as it's abbreviated, for diagnosis. It just hasn't moved into common use because people haven't done the tests with the validating instruments, shown how it might change things down the line. So it has the potential, but somebody needs to move it forward as a diagnostic test in a more formal fashion, and I'm not aware that that's happened.
Thank you.
Thank you for your great work. I'm curious, I understand that children who have Down syndrome are statistically more likely to eventually develop Alzheimer's disease. And I was wondering if there are any current or prospective studies that will be done to analyze whether or not children with ADHD or learning disabilities are at a greater risk for developing Alzheimer's the way the children with the greater struggles have.
Yeah, wonderful question. So Down syndrome is different than the other conditions because it's a genetic condition that has to do with the same gene of one of the Alzheimer genes, with the overproduction of amyloid. So in fact, it's not a statistical link, it's a deterministic link. By age 40, pretty much everyone with Down syndrome has Alzheimer's in their brain. It might be hard to discern the symptoms because they are in the same space, if you will, to someone more forgetful or not. It can become a challenge. So with regard to the other conditions, they don't share that very unique genetic relationship with Alzheimer's disease, but yet there is the concern. It's very difficult to do the research. And in fact, we're having conversations with our partners at Kennedy Krieger to talk about locating individuals who were cared for at KKI as children or maybe adolescents. Can we track them down in their 40s if they had attention deficit disorder or some other developmental condition, and understand what happens down the line? There is reason to be worried, but there's really no evidence so far that I know of that pulls it together.
Is there any way that people can advocate that that cohort, as the other gentleman was saying, this is another one like autism and ADHD is being diagnosed more and more frequently. So, you know, for that population, it's an expanding population. If they could be looked at, you know, long term, even if they did it just as a voluntary thing with their doctors who are prescribing them the medications to manage their ADHD.
Yeah, I would think whether it be with ADHD, with autism, there's an opportunity. The NIH research agenda is very much influenceable by advocacy groups. So if Autism Speaks, for example, wanted to work with the Alzheimer's Association to increase funding for this particular question, probably a little broader than autism and dementia, I think that you would, you know, we're in the US, money drives a lot of things.
Well, thank you. I like the Greek flag song.
Oh, thank
Those
you,
are
yes.
Hello, my name is Diego Louis, class of 2017. Thank you so much for your time, Dr. Lyketsos. My question is in terms, or regarding the biomarkers, how good are they really? Can you compare the specificity, sensitivity of each of these, the serum markers, the CSF markers, and the PET scan as well? And then I have a second part to that question.
So you're asking for figures I don't have at my fingertips, but if you leave me your email, I can get you that information. Probably the best compendium that I would get is the Alzheimer's Association publishes every year roughly Alzheimer's facts and figures for the year. The 2021 is the last one, and I think there's a treasure trove where you can get a lot of that. SenSpec depends on a lot of things. You're probably familiar with the term likelihood ratio, which is a way of incorporating sense and spec in diagnostic thinking. So we're talking likelihood ratios for PET scans on the order of 8 or 9, which is quite substantial posterior odds. much less so for example, ApoE gene testing. We're actually about to compile a list for that. So they're pretty high, depending on the test and depending on what gold standard you're using.
Perfect. Thank you so much. And then my second part of the question is, in the clinical arena, when do you foresee this becoming a standard exam or a lab test, say, like compared to lipid profiles that are accumulated over and over with a PCP? When do you foresee that being implemented, and at what age range?
You're talking about which test?
In terms of, say, the serum biomarker, as soon as that's available.
Yeah, so I think serum biomarkers are several years away from sense specs that will have clinical utility. And then they will have the added hurdle of, well, what's the point? So if there's no therapy or if there's nothing to do, so to speak, why would you want to know at 50 that you've got a biomarker profile in your blood that suggests you'll get Alzheimer's at 70?
Sure.
So I think both of those thresholds suggest to me that wide use for young people is unlikely for quite a while. But that in the kinds of patients who I see, we'll probably be having added utility from blood tests in the next 3 to 5 years.
Thank you so much.
Good morning, Gabrielle Barber, class of 91. So at the risk of being controversial, I know you recommended the Mediterranean diet. So I had been reading a lot about the MIND diet, and I wanted to know—
I'm sorry, the which?
MIND, M-I-N-D, it's a combination of the DASH diet and the Mediterranean diet. So I wanted to know, was there any particular reason other than you like Greece, you're from Greece, you're Greek, that you didn't actually recommend that? Or did you think that the research was like not really substantial as of now for that diet specifically?
First of all, it's a great question, and I am not against any particular diets, but I'm glad you're raising the point. For me, it has to do with the availability of evidence. So if you have evidence about MIND and DASH specifically with dementia, I'd love to see it.
Oh, yeah.
I'd love to see it. You will have taught me something.
Okay. Do you know Dr. Anderson? He's in Arizona?
Yeah, it's Kostas, K-O-S-T-A-S, at JHMO.
Oh, no, I was saying Dr. Anderson in Tucson. He actually had introduced us to it, and I'm from Chicago, so that's when they did the initial research on it. So
papers that show that.
Yeah, okay.
I mean, there are a lot of colleagues around the country that advocate specific interventions. Boot camps for the brain, this guy or gal's method, you know, so I'd love to see something that's actually got evidence.
Okay, no problem.
Yeah, thanks.
Yeah, hi, I'm Michael Burke, class of 72. I came in late, and I picked up on this point you raised about the Mediterranean diet and drinking red wine. And about maybe 10, 15 years ago, I had an intern tell me about the Mediterranean, and the guy is literally a doctor's doctor. He took care of my father-in-law, who was practiced medicine for 60 years. So we knew, and he raised the point, but he said, yeah, the drinking wine is beneficial, but at least at that time, he said, there's a question, is it the wine intake or the socialization that goes with it? So I'm just wondering, you know, how much evidence there is.
Yeah.
So Kostas, I'm just going to repeat the question because I know we're on live stream and I want to make sure everybody is hearing it. Sorry, I should have been doing that earlier.
Yeah, so the question was in relationship to my mentioning wine or Mediterranean diet, how much of the possible effect in preventing dementia comes from the socialization or other activities that what I would call confounders. And I think there's probably effects of all of the above, especially around wine. I mean, I think it would be very difficult to do what we call high-level evidence, a randomized trial, to answer the question. So we've got to rely on observational studies.
Yeah, because I mean, I could give you, you know, anecdotal evidence.
Yeah, but there are a lot of observational studies, large numbers of people, population epi, looking at what people do, suggesting that certain diets, but not others, and certain amounts of alcohol intake impacting the risk.
Yeah, now this point about antioxidants, is that what the key is?
So there's an antioxidant called resveratrol, which is one of the major antioxidants in wine that had been developed into pill form that was tried to treat dementia, and it didn't work. So does that, they didn't try it to prevent dementia, right? Which might be a whole different paradigm. It might work to prevent, but not work to treat. So
this doctor said he thought that there's about 90% certain that the antioxidants help.
yeah,
And, you know, I have anecdotal evidence that that's true.
yeah,
True.
yeah.
I mean, my mother was 6 weeks shy of her 97th birthday when she passed away. And every morning she picks herself a pot of coffee, fresh coffee.
Yeah. Lifestyle in relationship to late life outcomes is a hugely difficult thing to study just because lifestyle is over decades and we're talking about survival effects. Not everybody's built to make it to 70 or 80.
Okay, thank you.
Hi, Roy Martin, class of 85. My question is actually similar to this gentleman's, and you may not have a clear answer. When you started talking about wine intake, and you were mentioning a particular region of Italy, and my wife and I, we don't drink, and I was wondering if we need to potentially reevaluate this. And is grape juice the same as wine? Were you serious about a particular region? How much do we know? How much do we not know?
No, thank you. Thank you for putting me in the position to clarify. It's the right thing to do. I don't think we know enough to say it's about region or color of wine, or of course, Greek stuff is always better. I don't think we're in a position to say, and it actually, by the way, there's some evidence that it's not about wine. The benefit might accrue if you drink beer or have spirits. I'm not going to be advocating, though, that you start drinking, and certainly not in Baltimore.
Hi, Joanne Tilly Lee, now it's Lee, class of 1982. I worked in long-term care, and I've also worked with the autism community. And I can tell you stories of small children that they said would be institutionalized. And what they did was look at the methylation cycles, particularly the MTHFR gene, which I think was discovered here. And they've gotten this detox, a lot of heavy metal. And I can tell you a 3-year-old boy was toe walking, flapping, no speech. He is now at Carnegie Mellon 4.0, beautiful clarinet player up in Pittsburgh, very toxic, detoxed a lot of cadmium, lead, mercury. The mom used to call me every day. But mom did it full time because it was hard, but multiple B12, methyl tetrahydrofolate, plenty of minerals, saunas, detox, really worked on this kid, and beautiful kid. So, I mean, of course they're little, so they're more neuroplasticity, but Dr. Bredesen's book, I don't know if you're familiar with Dr. Bredesen, and 30 holes in the ceiling. So it's really a multiple. And I think they miss the heavy metal, Lyme's disease that's untreated, chronic inflammatory conditions that you may not know that you have. But it is a very difficult process to get at least the kids through, not to mention old people.
Thank
so the
you.
MTHFR, I think 70% of people have at least one of those, but I don't know why they don't do more with that in terms of a lot of different diseases, because it raises homocysteine, which causes inflammation. So I don't know why they don't look more at that.
Oh, I appreciate the comment. Thank you.
Hi, Jim Feely. Just wondering, any evidence of a relationship between statins and dementia or Alzheimer's?
Statins and dementia or Alzheimer's. Controversial evidence on both sides. I'm not sure there's clear evidence that overwhelms one side or the other. One of the potential values of statins that we're actually testing out has to do with some of the statins, and probably not because they are statins, seem to improve the ability of the brain to perfuse itself. And so many people have Alzheimer's, not because they have Alzheimer's, but because of age or other reasons. They have reduced brain perfusion. Their brain just doesn't get enough flow. You don't notice it day to day, but if you put them under stress, you notice it, and the brain has trouble. So it may be that statins will have a role down the line to improve brain perfusion in people whose perfusion is impaired. So a very narrow potential purpose. But other than that, I wouldn't make a decision about whether or not to use a statin if it's medically indicated, because it might cause dementia, and I wouldn't take it to prevent dementia either. It's pretty neutral from my read.
So we're going to take the last question over here, and I just have to comment that, of course, Hopkins alumni would absolutely make it perfect that you are right on time for the last question. So leave it to Hopkins alums.
My question has to do with the normal aging process that you were talking about. If you're 60% at 40 and you're 60 percentile at 70, that's normal. I'm 70. How do I know what percentile I was at when I was 40?
Well, I said usual. But okay, I'll
Is
make a slight
Montreal,
correction at that.
The Montreal Test, you mentioned something that we should all take?
It's a problem, isn't it, right? Because, so there are some ways to get a feel from where you were simply by formulas that take into account how educated you are and using certain particular tests. So you're given a list of, this works for English speakers primarily. So there are cultural variations for this, but the degree of your education, the occupation you had, the highest level of occupation, the highest level of education, plus this verbal test where you're given increasingly complex words and you're asked to pronounce them correctly, that gives a pretty good estimate of your percentile in your younger years. And it's not infrequent that our neuropsychologists use that kind of, it's a kind of an imputation to say, well, you were at 60th percentile or 70th or whatever. It's a useful test. But we have challenges across different languages.
Sorry, we actually have one online question, and that is the relationship of dementia to, or Alzheimer's to long-term statin use.
To what?
Long-term.
Statin?
Oh, long-term statin use, yeah. So I'm not aware of a relationship either way. So there's evidence to suggest that long-term statin use slightly reduces risk of dementia. There's evidence that it slightly might increase it. So I think the answer is somewhere in the middle. And so I wouldn't change long-term statin use if it's medically indicated because of a worry of getting dementia. Well, I'm glad you asked the question.
Yes, thank you. I just want to thank you all for coming, for inviting Dr. Lyketsos to be here this morning. I do have the Hopkins gift for him, and I think I failed to mention in my welcoming that he is an alum. So he's an alum of the
I am an alum.
Bloomberg
This
School.
is true.
So thank you all, and enjoy the rest of your weekend.
You've been a wonderful audience. Take care of yourselves. Thank you for coming.